Hi, my name is RAnderson, and today's presentation will comprehensively cover my Capstone data analytics project, with a focus on my findings regarding the impact of the Affordable Care Act of 2010 and the subsequent Medicaid expansion on American well-being as defined by socioeconomic and public health indicators. This presentation will begin with some context to frame the nature of the problem and its importance. The subject of this project is the Affordable Care Act, which was signed into law on March 23, 2010. The Affordable Care Act is also known as the Patient Protection and Affordable Care Act, the ACA, and Obamacare. This Health Insurance Act was accompanied by the federal government's decision to broaden eligibility for Medicaid coverage, which is administered by state governments, as a way to further extend insurance coverage. Medicaid expansion formally began in 2014, but some states adopted the expanded eligibility rules as early as 2010. The stated goals of the ACA were to reduce the number of uninsured people in America, increase Americans' access to health care, and improve U.S. public health. The ACA is a nationwide program available in all states. Expanded Medicaid eligibility is available in 38 states and Washington, D.C. as of 2022. 12 states have still not adopted it. More than a decade after the passage of the ACA and nearly a decade after the follow-on Medicaid expansion, the value of the programs and their success remain a matter of public debate. This has led to swings in healthcare policy that depend on the party in power. I selected this project to gain an understanding of the impact of a major policy decision on Americans' quality of life. Although U.S. government agencies have kept detailed metrics relevant to evaluating the ACA and Medicaid expansion, the major shifts in policy direction and the pandemic emergency make it difficult to determine the level of success by simply observing the data. A model-based approach that isolates the impacts of the many moving parts is a necessary part of this analysis. This project is important because it will demonstrate whether the kind of investment that the ACA and Medicaid expansion represent can pay off in the long run. Are the costs balanced or even outweighed by quantifiable benefits to citizens and society? The financial costs of the ACA and Medicaid expansion are substantial, $205 billion this year and $2.5 trillion over the next 10. Nearly 28 million Americans remain uninsured today, either because the cost of coverage is too high or they can't participate in Medicaid expansion because the state they live in has not implemented it. Regardless of the finding, then, the results of this project should inform future public health care policy decisions. The rest of this presentation will cover my data analytics process and the insights I gleaned from the data exploration phase, as well as from the models themselves. I will follow this by evaluating the analysis and what we can say about the impact of the ACA and Medicaid expansion, and conclude with areas for improvement and future research. The models built for this project drew on data from 3 sources. The Census Bureau publishes data every year for every U.S. county from the American Community Survey. This data presents a 5-year running average of metrics on a wide variety of indicators, including economic, education, and health insurance coverage that was used in this project. The University of Wisconsin Population Health Institute compiles health data from county-level measures published in a range of reliable national and state data sources. The compilers standardize the data and apply scientifically informed weights. These data capture a range of environmental, behavioral, and self-reported health indicators to create a comprehensive picture of county-level public health. The CDC's reported COVID-19 data were compiled by USA Facts, a nonpartisan nonprofit organization that asserts it does not operate with a political agenda. Its data on COVID-19 cases and deaths per 100,000 people comes from the official data reported by the Centers for Disease Control. The data sets together cover 3,143 counties, all of the U.S. counties and county-like jurisdictions, with a total of about 30,000 observations. The Census Bureau and the University of Wisconsin data cover 2012 through 2019, and the COVID data cover 2020 and 2021. Although the data for this analysis are drawn from multiple different publishers, they all come from reputable, reliable sources, including the federal government and reputable, nonpartisan, nonprofit groups. In many cases, these are the data sources of record and have been tracked for more than a decade or longer, making the resulting data sets about as robust as they can be. The data analysis techniques for this project fall into 3 consecutive buckets, beginning with univariate, bivariate, and multivariate visualizations. These plots will show the distributions of the variables to determine the normality of the distribution and the visual relationships between 2 or 3 variables. The second bucket, referring to simple models, includes association rules and simple decision trees to identify more complex multivariate relationships and test for significance. The third bucket comprises complex classification models, specifically random forests and gradient boosting trees, which generally can provide more robust models than decision trees, but with less transparency. The final set of models are multiple linear regressions, used to examine the links between insurance, economic, education, social, and public health factors, and the rate of COVID cases and deaths. This chart displays changes in public and private health insurance coverage for people who were employed and unemployed from 2010 to 2019, with a trend line and confidence bands. This allows us to validate the fundamental assumption underlying this analysis, that the share of the population with insurance coverage, both privately purchased and publicly available through Medicaid expansion, increased in the years following the ACA's implementation and as the duration of Medicaid expansion programs went on. Separating employed and unemployed populations also allowed validation of the assertion by the Obama administration that people who had jobs but lacked employer-provided health insurance could benefit from the program by obtaining affordable coverage, and that the program would not benefit only those without jobs. Separating the groups this way also helped to visualize the variation in status quo anti-coverage. The chart shows, for example, that the group of people who employed and had private insurance started out and maintained a higher rate of coverage than any of the other groups. Private insurance coverage for employed people at its lowest was about 75%, which was a greater share of the coverage than even the highest rate of coverage among the other 3 groups. The chart showed that the fundamental assumptions all held true, and that insurance rates rose with the amount of time a jurisdiction participated in Medicaid expansion, regardless of employment status or type of insurance, although the magnitude of change varied. The plot for the median share of unemployed populations of the counties that were privately insured shows a more pronounced positive correlation with the length of time with expanded Medicaid enrollment in place. This plot is the most directly relevant to the Obama administration's assertion that the ACA would divorce access to health insurance coverage from employment. Prior to the ACA, most Americans who had access to private insurance accessed it through employer-based plans. A goal of the ACA was to make more health insurance plans with more comprehensive coverage available to Americans regardless of their employment status. The administration also claimed that the program would relieve some pressure on people who either lost their jobs and were facing resource constraints, or who were trapped by their need for health insurance in jobs they did not want or that did not serve their best interests. The plot suggests that the administration was successful because the number of unemployed people with private insurance, which you can see in the blue line, rose the longer the policies were in place. The plot showing the median share of unemployed population with public coverage, which is the gold line, shows the most pronounced relationship of the 4 groups. The exponential trend lines appear to fit the data closely and reflect a strong relationship. Examining public health coverage rates among unemployed people in particular, the data suggests that the rates rose most sharply in the first 4 or 5 years of expansion. This makes sense because there is probably a natural saturation point, particularly when the unemployment level is relatively stable, so that the proportion of the population that is unemployed is not very different from year to year. Using percentage shares of the population mitigates the potential impact of bias from population growth on the trends. This visualization tracks educational attainment over time, specifically bachelor's degree or higher, by year from 2012 through 2020. The purpose of this visual was to surface differences in apparent relationships between educational attainment and expanded Medicaid eligibility by gender. Educational attainment is presented as a percentage share of the subject population that has attained a bachelor's degree or higher. The visualization of educational attainment over time is categorized in 2 important ways. Overall, that is a percentage share of the total at the top, parsed by gender with a percentage share of females in the middle and the percentage share of males on the bottom. The groups, represented by the colors and shapes, are early for locations that adopted Medicaid's expanded eligibility rules before 2014, which is shown in green, on time for jurisdictions that adopted it in 2014, cautious for jurisdictions that adopted expansion between 2015 and 2019, and COVID for jurisdictions that adopted expansion during the pandemic, all shown in shades of blue. And finally, in red, the holdouts, the jurisdictions that have not adopted expansion to date. Overall, educational attainment increased for each Medicaid expansion group over the time period displayed. With respect to differences between Medicaid expansion groups across genders, and educational attainment among early adopters started higher and remained higher than all other Medicaid expansion groups over the time period displayed. In both the overall section and in the male section, the educational attainment by the early adopter group can be seen to have increased by more over the time period than the educational attainment of all the other Medicaid expansion groups. Additionally, overall and across gender categories, educational attainment of the on-time, late adopter, and COVID adopter groups are nearly overlapping and consistently about 4 to 5% lower than the early adopter group. The holdout group, while still seeing relatively modest gains over the time period presented, starts, maintains, and ends with the lowest educational attainment of all Medicaid expansion groups. The plot of the early group and the holdout group, in particular, suggests that educational attainment might have driven the policy choice. More educated jurisdictions generally chose to implement expansion, and less educated jurisdictions did not. The models should provide more insight into this dynamic. The final example of a multivariate comparison shows the relationship between median income in 2019, going into the pandemic, and the percentage of the population that died from COVID in 2020 on top, and in 2021, the chart on the bottom. The color coding allows for one more dimension, which is the Medicaid expansion group to which the county belonged. Without the expansion group dimension and the trend lines, it would have been difficult to discern any sort of relationship. However, the charts seem to show that COVID death rates in counties that expanded Medicaid eligibility early on had relatively inelastic change with respect to median outcome in COVID deaths. The early expansion counties and their trend lines are shown in dark gray, which is nearly horizontal in both 2020 and 2021. Essentially, there is not as much of a penalty for being less well off in places that had expanded Medicaid eligibility. In contrast, counties and states that expanded Medicaid eligibility after 2014 or not at all, which are shown in the lightest gray, pink, and red trend lines, showed a much stronger inverse relationship between COVID deaths and median income, where relatively wealthier locales experienced lower rates of COVID deaths than relatively poorer counties. This relationship was particularly pronounced in 2021. This suggests that Medicaid expansion had a mitigating effect on the likelihood of death from COVID among people with lower incomes. With the previous data exploration in mind, the modeling process began. First with association rules using the a priori method in R, followed by decision trees and complex supervised classification, all looking for the relationship between Medicaid expansion and insurance coverage more generally, and the outcomes of interest in economic, education, social, and health well-being. The last set of models were multiple linear regressions of COVID cases and deaths against all of the insurance, economic, education, social, and public health factors. The association rules took a binary target, Medicaid expansion, whether they were participant or non-participant, eliminating the time series component of the analysis. The process generated 11 distinct rules for counties that participated in Medicaid expansion and 45 distinct rules for counties that did not. The rules for the participants were more significant overall, with a lift of between 1.86 and 2.22. Rules for non-participants, by contrast, had lifts ranging from 1.15 to 1.49. This chart of the rules associated with participating in Medicaid expansion showed that Medicaid eligibility expansion is associated with higher rates of insurance coverage, both public coverage and general health insurance, among employed and unemployed people. It also shows that expansion counties are associated with a higher percentage of insured among Hispanic and Latino youth and white populations. Moving on to the decision trees, these models were focused around a target that was the expansion group, divided into 5 categories: early, on time, cautious, COVID, and holdout. These models all had relatively high validation and misclassification rates, from between 45% and 48.62%. The most robust tree actually was the tree that included all of the explanatory variables. Although the misclassification rates made the models less useful as a generalizable predictive tool, there is value in transparent binning. The most important explanatory variables that emerged from the decision tree modeling process were the percentage of live births with low birth weight, the percentage of population with a high school or higher educational attainment. These were correlated as would be expected, with fewer low birth weight babies and higher educational attainment in locales with higher rates of insurance. The value of the decision trees is in the ability to transparently see the path of the relationships. This screenshot of the champion decision tree model demonstrates the transparency value of this model type. This pathway begins with relatively higher rates of uninsured adults beginning to be concentrated in the group of holdout counties, those counties that are not participating in Medicaid expansion. In the next node, the holdouts are further concentrated in the node reflecting the higher rates of low birth weight live births. The next node shows further concentration in the group with relatively lower high school or higher educational attainment. The holdouts are then further concentrated in the node with higher STI rates. Interestingly, these counties made up a larger share of the counties with lower adult smoking rates. But again, looking in the final node, the holdouts are the largest constituent group in the node with relatively higher rates of adult obesity, constituting more than 80% of the observations. Of note, very few holdouts appear in the final node for relatively lower adult obesity rates. The random forest models also used expansion group membership as the target variable. The random forest models were most robust when limited to one category of explanatory variable: educational outcomes, economic outcomes, social or public health outcomes. The champion model in this category relied on educational attainment to predict the expansion group. Here, the results suggest that the counties and groups that expanded Medicaid eligibility earlier saw greater improvements in male high school or higher educational attainment, higher rates of health insurance among the white population, and higher high school or higher educational attainment among female residents. The gradient boosting trees, again with the same target expansion groups, were most robust when limited to social and public health explanatory variables. The findings in the champion gradient boosting model validated findings from earlier studies. The strongest relationships were between Medicaid eligibility expansion groups and the percentage of live birth weights with live births with low birth weight, the percentage of the violent crime rate, the percentage of the adult population with excessive drinking, and the percentage of the Medicare recipients who were diabetic who received insulin, as well as the percentage of the adult population that reported smoking. The final component of the project was using multiple linear regression models to evaluate whether or not the ACA and Medicaid expansion impacted the rates of COVID cases and deaths at the county level, either in a direct relationship between the rate of health insurance or indirectly through economic, educational, social, or public health outcomes. The results of these models are significant, but the champion model did not provide a particularly useful insight. In this model, which had a test-adjusted R-square of 0.72 and relied on the full set of 126 explanatory variables, the most significant predictor of the percentage of the county population that would contract COVID in 2020 was the percentage of the population that would die from COVID in 2020. Each percentage point increase in deaths was significantly linked to nearly 9% increase in cases. It seems fairly obvious, though, that there would be a strong positive relationship between COVID cases and deaths. The more interesting result came from a model that wasn't the champion. This model used COVID cases in 2021 as the target and found a strong, significant negative relationship between the percentage of the population that contracted COVID in 2021 and the percentage of the population that died from COVID in 2020. Specifically, for a 1 percentage point increase in deaths in 2020, there was a nearly 4.4% drop in cases in 2021. One interpretation here is that people who experienced knowing someone who died from COVID took more precautions going forward, and this had an impact on the case rate the next year. This would be an important finding for U.S. healthcare policymakers, particularly those that are responsible for developing preventive measures and communicating them to the public. Although several of the results of models were interesting, the models ultimately do not provide clarity on whether the investment in the ACA and Medicaid expansion is justified. There are small indications of gender and race effects, as well as impacts on economic, educational, and public health outcomes, but nothing with a significance or magnitude to set this debate to rest. Although these models are not definitive on their own, the indications from the results would justify further investigation and modeling. At the time this project was developed, the most recent data available for most of the explanatory variables was from 2019. For the COVID models, the relationships might be more clear with concurrent data rather than lagged explanatory variables. Likewise, the results might become more definitive over time. The lack of understanding about COVID causes, especially in the first year, likely undercut the value of healthcare access. We simply did not know how to treat it. Another variable to include in a future study would be availability or stock of healthcare infrastructure, from hospital capacity to medical supplies, like personal preventive equipment. These may have had more of an effect early on in the pandemic. Other factors could also be included in a larger study of the impact of Medicaid expansion on public outcomes, including voting patterns, political party in charge at the state level, and other more fixed conditions that may have impacted program efficacy and outcomes. Finally, although the data sources themselves were reputable and reliable, there were significant gaps in data, particularly for public health indicators. The COVID data were also not as high quality as they could have been, with variations in how counties and states counted and reported COVID cases and deaths. To conclude, this project underscores the importance of evaluating program outcomes, not only against explicit measures of success, but broader impacts on the public. Given the scope and scale of the ACA and the ongoing public health concerns, there will certainly be continued opportunities to revisit this issue. Thank you so much for your time. The next few slides will show the references for this presentation. Thank you.